A non-rebreather mask can deliver a seriously high oxygen concentration to a patient. Does that automatically make it a high flow device? Hang on to that question. We're about to spend the next few minutes taking it apart because the answer isn't as obvious as it sounds. Let's start with the why we give oxygen at all. The goal isn't just cranking up the flow meter. The goal is adequate oxygenation. That is, getting enough oxygen into the blood to meet the tissue's needs, using whatever device actually fits the patient in front of you. And it doesn't stop once you've picked a device. You have to reassess. You check the patient's response and you adjust. Device selection is step one. Here's that question again. Does a high oxygen concentration automatically mean a device is a high flow? And the answer is no. And this is one of the most important distinctions in this entire unit. So let's slow down a little bit on it. A device's FiO2, which is the concentration of oxygen it delivers, is one thing. Whether that device is low flow or high flow is something else entirely. Here's the difference. A device only earns the label high flow or fixed performance when its total output flow meets or exceeds the patient's inspiratory demand. If it can't keep up with how much air the patient is actually pulling in, the patient ends up in training room air around the edges of the device to make up the difference. And that dilutes whatever FiO2 you thought you were delivering. That's what we call low flow or variable performance. The actual FiO2 the patient gets shifts depending on their breathing pattern. So go back to the non-rebreather. Yes, it can deliver a high FiO2, 60, 70, or even 80%. But its total flow still can't fully match a hard breathing patient's peak inspiratory demand. That's why we classify this as still low flow and a reservoir system. High oxygen concentration, low flow performance. Those are two separate things, and you need to be able to say why they are. Let's put this into practice with the first device, the nasal cannula. This is your low flow variable performance. For adults, flow runs about a quarter liter to 6 liters per minute, and FiO2 lands around 22 to 40%. And you hear the rule of thumb we use in lab that every extra liter per minute adds about 4% FiO2. That's a useful estimate because it's quick for bedside math, but that's all it is. It's just an estimate. It doesn't account for a patient's respiratory rate, their tidal volume, or whether they're breathing through their mouth instead of their nose. Two patients on the same 2 liters per minute end up with varying FiO2 ranges. Think about our first patient, awake, talking to you, breathing at a normal rate and depth, just needs a small bump in his oxygen. A nasal cannula fits that patient pretty well. It's simple, it's comfortable, and a small variable FiO2 range is exactly what that situation calls for. But if the same patient's breathing pattern changes, getting more faster, rapid, shallow, um, or more distressed, that estimate you were using stops being reliable and their FiO2 can drift below what you think they're delivering. Next is a simple mask, also a low flow, also a variable performance, but built for a bit more oxygen than the cannula can comfortably deliver. Flow runs 5 to 10 liters per minute, and the FiO2 is roughly 35 to 55%. Here's a rule that you can't skip with this device. Flow has to stay at least 5 to 6 liters per minute every time without exception, and that's because the mask body itself holds a small volume of dead space. If the flow drops too low, the patient starts rebreathing their own exhaled carbon dioxide sitting in that mask instead of flushing it out. Now let's move to the reservoir system. That's the partial rebreather and non-rebreather. Both add a bag that stores oxygen between breaths, letting them push FiO2 much higher than a mask would alone. So we'll start with the partial rebreather, and the minimum flow is about 10 liters per minute. The FiO2 is roughly 40 to 70%. There are no one-way valves on this bag. The non-rebreather takes the same reservoir bag idea and adds one-way valves. Those valves block exhaled gas from re-entering the bag. and usually block room air from leaking around the mask. Same minimum flow, about 10 liters per minute, but the FiO2 climbs a little higher, commonly 60 to 80% with the standard mask. So think back to our second patient. They were significantly hypoxic, working hard to breathe. That patient needs more than a cannula or a simple mask can offer. A reservoir system sized to their need is built exactly for this. Now, a different category, the oxygen conserving devices. These are still low flow, variable performance, but they're built around one goal, getting a patient the oxygen they need while using as little gas as possible. The reservoir cannula looks like a regular nasal cannula, but it has a small pouch. Sometimes at the tip of the nasal cannula where you put in your nose and they call it a mustache, sometimes as a pendant. Those things store oxygen between breaths. That stored oxygen gets delivered right there at the start of the next inspiration when it does the most good. That means you can often maintain the same SpO2 using less flow, which extends how long a portable oxygen supply will last. Then post demand systems take this even further. Instead of a continuous flow, the device senses at the very start of the patient's inspiration and delivers a pulse of oxygen time to it. Performance varies on this one. Both of these exist for the same reason: portability and conservation, especially for patients on long term oxygen therapy who are up and moving around. Then the transtracheal oxygen is another oxygen conserving device, low flow system, but very different delivery route. Instead of the nose, oxygen goes directly into the trachea that through a small catheter that's placed precutaneously between your second and third tracheal. But this device can carry a real risk, the risk of infection at the site, mucus plugging, the catheter becoming dislodged, or tract closing if it's not used. And since it's surgically placed, there is a risk of surgical complications. And daily catheter care is not optional. And one rule that never gets skipped: a conventional oxygen device must be available as a backup all the time. All right, last stop. A quick look at high flow and controlled delivery systems you'll see more about later on in this course. The air entrainment mask uses a jet of oxygen to pull in a set amount of room air, delivering a fixed, predictable FiO2 as long as the total flow keeps up with the patient's demand. And we'll come back to exactly how that works in another video. The high flow nasal cannula delivers heated, humidified gas at flows up to 60 liters per minute or even more, which is enough to wash out dead space in the nose and throat. But for now, I just need you to know it belongs in the high flow category. And then we have the oxygen hood, which creates an enclosed oxygen environment around an infant's head with flow high enough to prevent carbon dioxide from building up inside it. And then there is the air oxygen blender, precisely mixing air and oxygen at a set source pressure to deliver an exact FiO2, anywhere from 20 to 100%, used to feed hoods, ventilators, and high flow nasal cannula systems with a reliable, precise mixture. So let's close this loop. Here's your question: is a device classified by how high its FiO2 can go, or by whether its total flow can meet the patient's inspiratory demand? It's the second one. Flow performance, not FiO2, is what makes a device low flow or high flow. So let's go back to our two patients one more time. The awake, stable patient needing a small amount of oxygen, which we use the nasal cannula, the low flow variable, and that's fine because their demand is modest and steady. But that severely hypoxic patient working harder to breathe, they need a reservoir system because a small device simply can't keep pace with how much air they're pulling in. Device names and FiO2 ranges are a starting point and not the finishing point. What actually matters is flow performance, whether there's a reservoir doing the work, what the patient's demand look like, and how stable the delivered FiO2 really is. Hold on to this framework and we're going to build on it in the next video.